Okay, everybody, welcome to our next hashtag Vave EduCast. I'm Renee Deversdahl, honored to be here as Vave's Chief Medical Officer, super Pocus fanatic, and Pocus education lover. And I'm so excited about the really, truly fantastic panel of speakers that we've been able to put together here. So I'll introduce them one by one as we go through, but we're joined by, in the order they'll speak, Dr. Sally Gralia, Dr. Grace Juanjiku, and Dr. Mina Ramos, all of whom have truly phenomenal international and global health experiences that they're going to share with us. And I really hope you enjoy seeing their stories as much as I do. I do have to say, normally I'm at home on 2 laptops, and so I'm doing it from the road this time. So please bear with me with the tech. And I'm going to go ahead and pull over Dr. Sally Gralia first. We'll introduce her, and then I'm going to pull up her slides. So Sally, let me get to you. Okay. So now we have Dr. Sally Gralia, who is coming to us from the University of California, San Francisco. So she actually did her emergency medicine residency there at UCSF and then did her Pocus fellowship at Massachusetts General Hospital. We happened to meet in Slovenia at a really, truly fantastic WinFocus World Congress over in Slovenia. And so that was the first time we met. And it was right as she was getting close to finishing her fellowship and planning to go abroad and do more global work. And so since that, she's gone back to University of California, San Francisco again. She's on the faculty there, super involved in medical education, and is an assistant professor. And she's going to tell us about some of her passion and works. So give me a moment, everyone, while I get Sally pulled up here, get her slides rather. So we're going to go with this. Thank you for your patience. Right. And I have to get Sally's face here. Beautiful. Okay, so Sally, I'm going to hit, and I introduce everybody as doctor the first time, and then we're going to go by first names because it's easier. So I am going to put us in presenter mode here, and you're going to let me know when I need to forward, and I hope everybody really enjoys these fantastic cases.
All right. Thank you for that generous introduction, Dr. Deversdahl. Again, my name is Sally Gralia. It's a joy and honor to be a part of this exceptional panel, briefly sharing some of my experiences with point-of-care ultrasound. Whenever I speak about Pocus, my goals are always the same. Number one, to demonstrate the utility of Pocus in all environments and really showcase the magnification of that utility in low-resource environments. 2, to provide myself as a resource for you in any way that I might be helpful to you. And 3, to spark a love affair between you and point-of-care ultrasound. Next. All the cases I'll be sharing with you in these next few minutes are going to be from my previous work in Liberia. Liberia is shown here on the west coast of Africa. In 1822, freed-born and freed Black people from the U.S. began to settle in Liberia. And as you can see, the Liberian flag bears a lot of resemblance with the American flag. Liberia established its independence from the U.S. in 1847. Next. Liberia is beautiful in its vibrance, next, in its culture, next, in its food, next. Liberia is just beautiful. Next. In its heyday, Liberia had a bustling economy. This is the Hotel Ducor in Monrovia, Liberia in the 1970s. Built in the 1960s, the Ducor was at the highest physical point in Liberia. Next. It was the first international class hotel, and for years, it was one of the few 5-star hotels in Africa. Next. This is what the Ducor looks like today. Next. Next. So what happened? As many countries have experienced and endured, between 1980 and 2003, Liberia endured 23 years of instability, 14 years of violence, and 2 civil wars. During that time, many Liberians died or fled the country. Next. In the aftermath, in 2006, there were 51 physicians for a population of almost 4 million people. Next. And then March 30th, 2014 happened. It was on this date that Liberia confirmed the first 2 cases of Ebola in the country. Next. By 1 year later, 0.1% of the entire Liberian population had died due to Ebola, which translated to a 10% reduction in physicians in Liberia, which, remember, already had only 50 to start, not to mention an 8% reduction in nurses and midwives. Next. Point-of-care ultrasound is critical in my current clinical practice in a very well-resourced environment. Next. But in low-resource environments, where there may not be regular access to advanced imaging, or there may not be the radiologist to interpret those images, point-of-care ultrasound makes even more sense. Next. It was in this context that I had the privilege of taking a role to actually develop the ultrasound track. Next. My job that year was to train an interdisciplinary cohort of residents from pediatrics, internal medicine, surgery, family medicine, and OB-GYN in point-of-care ultrasound. And I will say that this opportunity was made available to me through the wonderful work of PURE, point-of-care ultrasound in resource-limited environments, and also through mentors and colleagues at the Boston Children's Hospital. It was a total joy. Next. So I'd like to share just a few pertinent cases where point-of-care ultrasound not only changed management, but really improved the lives of people. Next. I'm sure many of us have heard about the use of point-of-care ultrasound in the setting of trauma. Next. This first case is one of the classics. This was a 17-year-old male who presented after blunt trauma while on a motorbike. In the emergency area of the hospital, they were unable to obtain a blood pressure for this patient, and they noted that the patient had cool extremities. There were abrasions to the patient's shoulder, but no external signs of bleeding, no obvious long bone fractures or chest wall trauma. Next. This first image is what you might see as your first clip when performing the FAST, the Focused Assessment with Sonography in Trauma. And what I hope you can appreciate here, forgive me, I can't use my cursor, but that bright white curvilinear line in the bottom left side of your screen is the diaphragm moving up and down. Everything to the right of that bright white line on the left side of your screen is intra-abdominal contents. And you can actually see the liver, the kidney, and loops of bowel. And then I hope you can appreciate some black areas filling all the cracks and crevices between organs. That is all anechoic or free fluid. Next. This next image is a little more subtle. This is what you might see in the left upper quadrant. Again, you can see that that curved bright white line at the bottom left side of the screen is the diaphragm. And then along that line going parallel through the screen is the spine. You can see the spleen up in the near field and also the left kidney. I hope you can appreciate the subtle finding of some black or anechoic fluid creeping around the inferior tip of the spleen. Next. And finally, shown here is a transverse view of the pelvis. That big circle that's well circumscribed, that's the bladder filled with urine. All of that black or anechoic fluid sitting on top of that bladder is free fluid. That's all blood actively filling the abdomen. Next. Based on these sonographic images, that young man went to the operating room with surgery. He had an exploratory laparotomy with a confirmation of a splenic rupture, and after splenectomy, he actually did very well and was discharged 1 week later. Next. This was another trauma case. This was a 4-year-old who was brought to the family medicine ultrasound room for evaluation. The 4-year-old had tenderness to palpation of his belly after a fall from a tree. Next. The providers were concerned that this patient too might have some free fluid in the abdomen because he was so tender after a fall from such a great height. And what you can see here is very similar image. You can see that hyperechoic white line moving up and down as the patient breathes. You can see the spine all the way across the field. And then just below that diaphragm, you can see the liver. And just below the liver, you can see a very bright, big kidney. So we finished the rest of the fast and we didn't find any evidence of intra-abdominal free fluid, no pericardial fluid, no evidence of a pneumothorax or hemothorax. But what we did appreciate was that this kidney was very bright and very big. Next. As I said, the fast was negative. This patient ended up appropriately going to the OR with persistent tenderness to palpation despite a negative fast. But whenever you see a big, bright kidney, you want to consider HIV nephropathy. We recommended to the primary team to order an HIV test, and this kiddo was diagnosed with HIV. It was positive, and they were able to start him on antiretrovirals. Next. Many of you probably also use cardiac in your day-to-day. And in low-resource settings, you're going to use cardiac also. You may think commonly about TB-related pericardial effusions, or you might see something like in this case. Next. This was a 50-year-old gentleman who actually was admitted to the internal medicine ward. He was complaining of severe chest pain that was radiating to the back. He was noted to be very ill-appearing. He was diaphoretic, was having a hard time breathing, and clutching his chest. Next. This is a still image of a parasternal long view. That first triangular chamber just below the probe is the right ventricle. The left ventricle is on the bottom right side of the screen. You might see the mitral valve that's emptying into the left ventricle from the left atrium. And then what is being measured is actually the aorta. It's the diameter of the aorta. And if you notice the measurement in the bottom left side of the screen, it measures about 4.8 centimeters, whereas the upper limit of normal would be about 4.5. So this was a dilated aortic root. Next. Shown here is a less commonly obtained image, but this is the suprasternal view, meaning that you take your probe, anchor it on the suprasternal notch, angling down, looking at the aortic arch. And I hope you can appreciate that nice circle of the aorta, but you might see a diagonal flap across the aortic lumen. Next. And then finally, this is a transverse view in the abdomen. There's a little slither of the IVC on the left side of the image. And then again, on the right side of the image, you can see that circle of the aorta with a flap going across the aortic lumen. Next. Given this patient's severe symptoms and EKG changes concerning for active ischemia, the team was appropriately concerned about a type A aortic dissection. There was no ability within Liberia to have definitive management, but the family was able to gather the funds and send the patient to Ghana for definitive surgical repair. This patient walked back into the clinic, walked back into an internal medicine clinic to thank those providers for their diagnosis and assisting him in his care, alive and well. Next. I'm sure many of us also turn to ultrasound in the setting of right upper quadrant pathology, thinking about acute cholecystitis or cholelithiasis. Next. This was a 50-year-old gentleman who presented with abdominal pain, nausea, fevers of unclear etiology, and right upper quadrant tendon palpation. Next. This image is the liver, shown in a similar fast view. And I don't know if you can appreciate this, but the left side of the screen, just below the diaphragm, has really heterogeneous tissue. Next. This is a transverse view of the liver, and it may be easier to appreciate that there's areas of heterogeneous tissue. Next. This patient was diagnosed with liver abscesses. Liver abscesses are the most common type of visceral abscess. They certainly can have direct or hematogenous spread. There's no RCT for just antibiotics as treatment, and they do recommend surgical management if there's multiple, loculated, or there's an inadequate response to percutaneous drains. Next. This patient had 2 percutaneous drains placed at the bedside with purulent drainage. He was started on antibiotics and did very well with outpatient follow-up. Next. No discussion of point-of-care ultrasound in low resource or high resource settings would ever be complete without discussing OB care. So this was a 24-year-old female who presented for pelvic pain, abdominal pain, and vaginal bleeding. Next. She was very excited that she was pregnant, and when the probe was put on her abdomen, you can see here Wiggles. Wiggles is encased in something, and there's some thick surrounding Wiggles. Next. But unfortunately, when you look from that midline suprapubic view and you're able to see the uterus, and then you fan to the patient's right lower quadrant, you can see that Wiggles is actually nowhere inside the uterus. Next. This was an ectopic pregnancy that was about 14 weeks along. As we all know, the risk factors include a disruption of the normal anatomy, prior surgery, prior infection, congenital changes. Most ectopic pregnancies are in the fallopian tubes, but this was an ectopic pregnancy in the adnexa. Next. This patient, again, went to the OR, had laparotomy with removal of the ectopic pregnancy, and did very well postoperatively. Next. I know I'm running short on time. Oftentimes in my experience, there's times when clinicians will ask you to use ultrasound to help them understand what's happening with a patient, which is against everything I teach medical students, residents, and anyone who will listen to me, that when you're doing point of care ultrasound, you're generally approaching that patient with a yes or no question. Is there free fluid? Yes or no. Is there evidence of aortic dissection? Yes or no. Is there an intrauterine pregnancy? Yes or no. These cases were where the indication wasn't so clear, but Pocus certainly changed management. Next. This was a 40-year-old male who had left flank tenderness to palpation and fever and pain. The surgery team was appropriately very concerned about him and were planning on taking him to the OR for an X-lab. Next. What's shown here, we're using the linear probe, and if you can appreciate in the near field, the most superficial aspect of the screen, you're seeing kind of the normal infrastructure of skeletal muscle. And then in the middle, you're seeing this homogeneous conversion into something, and it's behaving like fluid, because when compressed, it moves out of the way. And then deep to that layer, you're seeing, again, the regular integrity of skeletal muscle. Next. I hope you can also appreciate on this clip that homogeneous layer is acting like fluid. There's subtle movement there with compression. Next. This patient had pyomyositis. Next. The patient was continued on antibiotics, had a bedside IND, and actually we were able to prevent the morbidity and mortality associated going to an operating theater in this environment. Next. I saved my favorite case for last because not often do you so visibly see the change as a result of your point of care ultrasound. This is a 12-year-old female who came in with right buttocks pain and spasms in the right lower extremity. She had an injection into her right gluteal area 2 days prior. Next. This image shows a side-by-side comparison. On the left side of your screen, again, is normal gluteal muscle. This is an image of her left unaffected gluteal area. And on the right side of your screen, I hope you can appreciate that all of that normal anatomy, you can't make out any of it. That hyperechoic area near the near field of your screen with that dirty shadow below, as soon as we put the probe on this young lady, I knew it was air. Next. Based on our ultrasound, the surgical team took her to the operating room, and when they opened her skin and the muscular area, they had a gush of air and dish soap appearing fluid along the fascial plane, consistent with a necrotizing infection. After her surgery, that 12-year-old was walking around on the floor. Her spasms improved greatly, and she was ultimately discharged home. Next. Ultrasound is truly invaluable in any setting. Next. But it is even more so in low-resource settings where you can put diagnostic capabilities in the hands of providers at the bedside. Next. Thank you for your time. I very much look forward to questions.
Okay. Thank you so much, Dr. Gralia. Thank you all for working with me as I also work on adjusting and everything. Those are fantastic cases, and I know we're going to have questions at the end. Really appreciate your time. So I'm now going to pull over our next friend and speaker. Now we have Dr. Grace Juanjiku, who we're very honored to have here as well. So she's an assistant professor of emergency medicine in the Division of Global Emergency Medicine at Warren Alpert Medical School at Brown. She is very passionate about the creation and evaluation of Pocus programs and has done a lot of work that she's going to tell us about, including nationwide rural Pocus training development in Kenya. So I'm going to go ahead and pull up your slides next. Again, everyone, bear with me as I do that. And very much look forward to hearing you. Okay, back to you. One moment while I switch to Keynote. Okay, you are ready.
Right. Hi, everyone. Thank you so much, Dr. Deversdal. It's an honor to be part of this panel and to participate. As Dr. Deversdal said, I'm an emergency physician and I work at Brown University, and I also spend a significant amount of time teaching clinical ultrasound in Kenya. So, Dr. Deversdal, I don't think my slides are up yet. But today, I'm basically just going to talk to you about my journey and how I got interested in this. So that would be on the next slide. I can just tell you a little bit about how I got interested in this, and hopefully also give you an idea of what point of care ultrasound looks like in rural Kenya and what the context is where we are trying to introduce this technology. So as a third and fourth year resident in emergency medicine at Brown, I started working with Emergency Medicine Kenya Foundation. So this is an NGO, and at that time they had started a rural ultrasound treatment program. And this is how I got involved with them, basically using my elective time as a resident to go to Kenya and start working with them. So as you can see, throughout this program, I started, in 2014, and throughout my time working with them, I have managed to interact with a lot of trainees who are healthcare providers working in numerous facilities across the country. So moving on to the next slide, I think that once we started, when I joined EMKF, we were still in the process of defining the curriculum and trying to figure out what we're going to focus on. And our guideline for this was the local disease burden. So this table comes from research that was done by Dr. Benjamin Washira. He's one of my co-trainers, looking at what are the primary reasons why people come into emergency centers in Kenya. So injury was number one. And as you go down the list, you can see, infectious disease was the second reason why people presented, mental health, and then obstetrics is one of the top reasons why people come in. And then, there's, cardiac reasons, respiratory. And so going down this list, you can start to see how point of care ultrasound plugs in terms of helping providers evaluate, injury, like doing EFAS for trauma. Obstetrics is a big indication, as Dr. Gralia talked about. So this was our guide as we worked on creating a curriculum. And then moving on to the next slide, one of the problems that we're trying to solve with this training program is the workforce limitation. So as you can imagine, we have very few doctors for patients in Kenya. We're very limited. The doctors that are there tend to work in the urban areas. And also, most of the doctors do not have specialty training. So the training program in Kenya is that after high school, you go to medical school for 6 years. After that, you do a year of internship that is required by the government for you to get your certification. And most of the doctors, like, that gentleman that is on your slide, that's the only training he has had. And he's been practicing as a medical officer. They're called medical officers without particular specialization. So radiologists, as you can imagine, at that time when I started, there were less than 200 radiologists in the entire country. And so the bulk of healthcare provision, especially in rural areas, is provided by mid-level providers. Clinical officers are the equivalent of physician assistants or PAs or nurse practitioners. We also work with nurses and community workers. And so this is, teaching point of care ultrasound to this group of people is part of task shifting. And as you can imagine, it's a very new concept, especially when we started working, introducing the idea that non-radiologists and non-radiographer healthcare providers can be trained to do point of care ultrasound at the bedside was a pretty new concept at that time, and I can talk about some of the challenges associated with that. So on the next slide, I'm going to talk about when I started with this program. It was quite new and it has grown and changed a lot. But at that time, we were working with a non-governmental organization that was a church-based organization called Christian Health Association of Kenya, or CHAK. They have a lot of hospitals all across the country, varying from larger regional hospitals to very small health centers and sub-county hospitals. So they wanted they were very interested and invested in having their healthcare providers train in point of care ultrasound. They also gave us logistical support, because they're a nationwide organization, technical support. They have an imaging department, and there were two gentlemen in that department that were so helpful for us in terms of identifying the people who need to be trained and making sure that once they get trained and they get their ultrasound machines, that they're able to maintain them, and things like that. So for a program that's starting, it's very important to be working or be affiliated with an organization that's very committed to your mission, and we found that they were. So moving on, the next group of stakeholders, and we were very privileged that we managed to get some funding and support in terms of equipment. So we worked with a non-governmental organization from Australia that basically gave us funding to purchase. They actually donated ultrasound machines to us. This is huge to be able to train people and tell them, hey, here's an ultrasound, go for it and use it. So they also gave us support for, our technical support guys, and they gave us some money for monitoring and evaluation of equipment. So on the next picture, I wanted to just give you a picture of the machine, the kind of machine we were working with. Low cost, affordable, durable machines that are still out there. I mean, they're still out there, they're still being used, but limited in terms of what kind of things you could do. I mean, modalities you could use. There's no color Doppler, there's no spectral Doppler. There's some things that you cannot do. But, some of the things, most of the things we were targeting was basically just basic 2D, ultrasound. And so, this is what we had out there. These are two nurses, and the gentleman in the middle is one of our technical support guys. So moving on in terms of the details of our training program, we focused on EFAST for injury, because that's the main reason why people come in. And also just in general, teaching people how to find free fluid, in different settings. Ectopic pregnancies or different presentations, where you might be trying to look for free fluid in the future. So we talked on that. And then next was, we focused on first trimester ultrasound and second and third trimester ultrasound. So the difference with this, with obstetrics, as Dr. Gralia was saying, it's a pretty significant indication for, when you go out there, in a lot of countries, in regions in sub-Saharan Africa, you train people in front of care ultrasound and you teach all of these modalities, but obstetric use always ends up being number one, mostly because people associate, ultrasound with obstetrics, but also there's a pretty significant need in terms of what presents into the emergency care centers. So, first trimester ultrasound is in our wheelhouse in emergency medicine, at least here in the US. But you find that I also had to learn and be able to teach second and third trimester on the next slide. Second and third trimester ultrasound. And this is because, these healthcare workers out there do not have access to OBGYN. They do not have access to radiologists or radiographers. And so we had to teach them to do focused obstetrics, just looking for emergent, things that might indicate that a patient will need to be referred or might need more advanced imaging. And, when you're working in a rural area, small little clinic, finding something and, the process of referring a patient out, it involves like, a significant resource allocation because, some patients have to pay out of pocket for everything. These are very, very resource limited patients. And so telling someone, hey, I think I found something, you need to go and see an OBGYN in the next time. You need to arrange transportation and go, it's a pretty large thing, as opposed to, doing the imaging and you find that, everything is normal, everything looks fine. It's okay. I can keep you here overnight until our OBGYN comes into the room or until you're in a better position to go and see something else. And so that's why we teach them second and third trimester ultrasound, although we are, emergency providers. So moving on, so those are the prime components of our curriculum. And then the implementation of it was that, through the NGO, through CHAC, we identified the trainees, and then we provided materials for them. So there's like a multimedia manual that was initially on a CD and then later on a USB that they can read, they can look at videos, they can do self-study. After that, they were required to take a test. So you have to take a test and pass really well to be invited then to come to the capital city for training. And this we found later on, we can talk later, that having people pre-study, it selects for highly motivated trainees, because they have to kind of do it on their own and study and take the test, and these people, even when you follow them up later, you find that they're doing much better because they're very committed. So they do the pre-test, come into the city, we do a 2-day hands-on only training, no didactics, because they've already done the pre-studying. After that, they would receive the ultrasound machine and an ultrasound log and go back to their facilities. So on the next slide is, talking about our follow-up procedure, which was so fun. I call it the Ultrasound Safari. And I got to do this as a fourth year during my elective time. So fun. As a trainer, what this means is that the trainers then, you go into the facilities in the country you travel, and go to the facilities themselves and do quality assessment. You look at the images that are saved on the machine. The machines we had, unfortunately, and that's one of the limitations we had starting, was that those machines you were not able to upload images for remote review. And so they would save the images onto the machine, we'd review it with them, test them, see how they're doing, and then kind of just troubleshoot any issues that would come up. So, the next couple of slides is just pictures showing you, just to get an idea. This is one of the clinics that we went to. I mean, these are rural, very remote places. So we drove through this region to get to the clinic. That's on the next slide, which is an absolutely beautiful. I love it. I haven't had a chance to go back, unfortunately. Tiny little clinic with beautiful bougainvillea flowers. And that gentleman there is a clinical officer. He had been trained 3 months before, so I was there to do his follow-up evaluation. And, when we got there, we found that his x-ray had broken down months before. He just did not have x-ray. CT and MRI, forget about it. The nearest town is about 5 hours away. And so this guy was using his ultrasound. When we went to evaluate him, he's one of the very few that passed the first time around. And that's because he's busy. He's evaluating a lot of patients, and this is the only modality that he had. And so he found it immediately useful for him. And it was upon, kind of took it upon himself to really be good at it and to scan a lot, obviously. So that's just, an example of, kind of the context in which you're trying to introduce this infrastructure. And then next, these are just additional. This is like, look at this. I mean, this is a tiny little clinic. There are 2 nurses that work here. It looks like someone's house, really. And it's they offer prenatal care, postnatal care, and they have like a small pediatric clinic where they see kids and give immunizations and do primary care. So, the next picture is one of the larger hospitals. And this one is interesting. I wanted to show you because their model of using point of care ultrasound was interesting. So they sent us radiographers. These 2 gentlemen are radiographers to train. Because the idea, I think they were trying to reconcile the idea of, taking an ultrasound out of the radiology department. And how they did it is that they have these 2 radiographers. As you can see on that picture, they have one large cart-based ultrasound, and then they have the portable one that we donated to them. And they basically would receive a call from the casualty or from the A&E or emergency department, and take the machine with them and go to the to the accident and emergency department, scan with the provider, and make an interpretation at the bedside, and then go back. So that's the model I think that made sense for them, and it worked. And so you kind of just go with what works for people. The next slide is basically just, I think I wanted to use this just to make the case that when you go to these healthcare facilities, a lot of them have these service charters, and it's their way of basically just showing the patients how much they expect to spend for every procedure that you get. So this is in Kenyan shillings. I don't know if you can see, for every consultation is this, this is how much you spend. And it's because a lot of patients do not have health insurance, and for these facilities, you kind of have to pay at the points of care for every service that you need. So the ultrasounds that were donated to them, we required them basically to not charge patients for them. So this was free to the patients, or even if they had to pay, it was a very minimal amount just to allow them to be able to get electricity, to charge it, and things like that. And so this is, resource saving for patients. So, if you can someone, avoid a chest X-ray, avoid a CT, that's huge. if you scan them and see that there's something going on, and you have to explain to them, hey, this is why you have to spend your money. I know it's hard, the money is hard to come by, but we really think it's worth it for you to go get the CT, or for you to go into the next town and to see a specialist. So so after that, we kind of did an evaluation of our program. Like I talked about, it's good to have people who study obstetric use is number one. And then on the next slide, we did a study, basically just looking at our model of training, because, it kind of, there's several iterations to it. We train, we evaluate you 3 months after that, and 4 months after that, and we keep going until the trainee is competent. And basically what they showed is that, the more contact we had and the more training sessions someone had, the better they did. And, that's very intuitive. It's like, oh, God, it makes sense. But, that's kind of what it showed. And then the other thing was that the longer the amount of time went in between the training sessions, the worse the trainees did. So this to us was, kind of just highlighting to us that we need to have a way of interacting more frequently with our trainees. So, the directions we're going into, like on the next slide, is trying to look for, telementoring platforms via Zoom. That's one project that we did with trainees from different facilities, trying to get them on Zoom. They use their telephone, they use their mobile phones to get on Zoom, because that's the way that most women get access to the internet. It's through their phone. So they get on Zoom, we discuss the cases they're seeing, and try to interact with them more that way. And the other thing we're trying to do, on the next slide, is trying to use more handhelds now, or just looking for solutions that are, portable, that we can connect to a phone, and that you can transmit images. This scan that I was doing here, I was able to save it and transmit it. The process of transmitting through local cell phone networks was 2 to 3 minutes. So this is one way in which we're trying to use this technology to create a platform for routine QA. So the next couple of images, I just wanted to show you other projects that we're involved in. This is at Kenyatta National Hospital. It's the National and Regional Referral Hospital. It's pretty busy. These are my colleagues that I work with there at the ICU. And we're basically just doing rounds, the rooms are small, many patients, they're, divided by curtains. And so you don't have a lot of room to maneuver a large machine. So, portability is huge in this setting. So the next couple of pictures is just showing us, doing rounds and, going from patient to patient. And, the next one coming after is a little video I wanted to play. He's a little kid, a 9-year-old who was in heart failure from rheumatic heart disease, unfortunately. So we're just, this is just an example. I think the gentleman that's talking is just talking about the utility of being able to use the ultrasound in this setting. I don't know if you can hear the audio well, maybe not. Yeah, so I think that's about it. I think, at least in the ICU, having something that's affordable, something that's portable, was really useful for them, because like if you can scan a patient and be able to diagnose like a PE at the bedside, the process of them actually taking patients to radiology is much more involved, because the ICU is like on the 9th level. And so if you need to scan a patient, they basically had to disconnect them from the vent. They don't have portable vents. So you have to kind of bag the patient all the way to the first floor to take them to CAT scan and back. So that takes away a doctor, it takes away a nurse. It's very involved. And so if there are decisions that can be made at the bedside without requiring, avoiding advanced imaging as much as possible, then it is helpful for them. So I think, most of our challenges, I think I've kind of talked about them, alluded to them. We're looking for a more robust training program with certification. Cost is a big thing that we try to address in our setting, and also coming up with a robust platform for image review and QA. So that's it from me today. Obviously, I could talk about this forever, and I'm happy to take questions.
Okay, Grace, thank you so much. That was truly fascinating. I love the pictures. I'm sorry that the audio didn't come through on those clips, but I was able to enjoy them here from my computer. So,
Okay.
let's see. Okay, so Dr. Ramos's don't have audio. So, okay, so rounding out here, I'm going to pull over the fantastic Dr. Mina Ramos. Let me get her here. Okay, sorry, this happens every time. I forget to hit send live. So anywho, now we are back with the fantastic Dr. Mina Ramos, who Mina, I'm super excited to have her here. I'm an internist. We've heard from 2 emergency medicine doctors. Mina's family medicine trained, and I think one of the things I love the most about the point of care ultrasound, global ultrasound educational worlds is that they're so inclusive and that we all have the same goals, which are the best care for patients everywhere, every setting. And so I'm super excited to have her representing her crew. So she did her family medicine training down in the Bay Area. The Pocus skills came from her residency at the Contra Costa Family Medicine Residency Program, which for years has been like one of the very, very forerunners, fantastic family medicine Pocus program. And so after that, and actually she came up and taught with us at OHSU one year at our July course several years ago. So after that, she did the Contra Costa UCSF Global Health Fellowship. And that was time spent in Malawi, where it was both clinical and educational work. And the next step, what she's going to tell us about, was she co-founded the Global Ultrasound Institute with Dr. Kevin Bergman, another POCUS friend of ours, and also co-authored a very important seminal piece, the AAFP curricular guidelines, which have been pretty instrumental for getting folks moving forward. So we'll see if I can be smoother about getting your screen share, okay? So let me get to Keynote, and I'll get you pulled up here. Mina, I'll make you the primary. Just one moment.
So here we are in southern Lucis, a small town, population primarily depends on teaching and science population. Next. Next. Here's the technical challenges. This is a 45-year-old male. He's a farmer who presented with diffuse abdominal pain that was waxing and waning over several days and progressed to the point where he was unable to get out of bed. Next. I asked myself, did he have an appendicitis? Next. Perhaps an infected gallbladder full of stones, as we're seeing here. Next. Perhaps a AAA. Next. Or maybe he had an obstructive kidney stone that was complicated by pyelonephritis and sepsis. Or maybe it was something else. Next. Unfortunately, his family did not have the means to seek medical care, and so never had vital signs taken, a physical exam, labs, or any imaging. Next. He progressively got sicker and over several weeks became bedridden and passed away on August 17, 1967. Next. Next. He left behind a family of 6, his wife, and 5 children. That patient was Francisco Ramos, my grandfather, and his eldest son, Bonifacio Ramos, my father. Next. I often wonder how things could have been different if he had access to care. What would his ultrasound have shown? Would he still be alive today? Next. 45 years later, I had the good fortune to study medicine at the Latin American School of Medicine in Havana, Cuba. Next. Followed by residency at Contra Costa Family Medicine, where I was able to learn and develop my ultrasound skills. Next. Here, we're seeing the ultrasound of a patient who had been misdiagnosed with pneumonia after presenting with cough, shortness of breath, and chills. I happened to be on my Pocus elective as a resident, and I performed this cardiac echo, which shows anechoic fluid around the heart. The patient progressed to develop hypotension and pericardial tamponade, requiring pericardiocentesis. So this was a real game-changing case for me and opened my eyes to the power of point-of-care ultrasound and the importance in bedside diagnosis for frontline providers. Next. As a Contra Costa UCSF Global Health Fellow, I taught ultrasound for clinicians at a rural district hospital in Malawi, where ultrasound before that had been used primarily for obstetrics. Next. It was really an incredible experience teaching heart and lung ultrasound, watching learners' eyes just get so big when performing their first cardiac scan, or just be in amazement that, hey, you can actually look at the lungs and interpret these artifacts, and that they give you lots of really useful information. And so here we had this machine that was locked up in a closet and only pulled out for obstetric scans, and there's a whole world of other applications that we can use it for to provide better patient care. Next. Needless to say, it was a really rewarding experience that taught me a great deal about the art of teaching. Next. In the years preceding, I continued to supervise Pocus training for Contra Costa Family Medicine residents, and I'm really proud to say that over the last 10 years, our residents have gone on to work at dozens of countries around the world and bring their Pocus skills with them. Next. I've taught many introductory 2-day courses, hundreds of family medicine residents and faculty. This is from a training program program in Alaska, where providers were working in places where they had to triage and make a decision as to whether to put their patients in airplanes to go to the nearest tertiary care hospital. So a fast exam was extremely important and potentially could make the difference between diagnosing a life-threatening condition, making the appropriate clinical decision. Next. I also had the opportunity to teach at a consortium of family medicine residencies in Kenya, an introduction to Pocus course. Next. And through these training sessions, introductory training, Pocus training sessions, I learned that while an introductory course is fantastic for getting learners excited about Pocus, to getting them to be familiar with the vastness and applications of Pocus beyond obstetrics and cardiology, it's not enough to get a clinician from point A to point B, from having some familiarity with the scan to being a Pocus provider, knowing when to perform a scan, what question to ask, how to interpret an image, and ultimately how to make that the best clinical decision for their patient based on the evidence. Next. So it was after these experiences that in 2018, the Global Ultrasound Institute was born, co-founded by myself and my colleague, Dr. Kevin Bergman, with a singular goal to train as many Pocus providers worldwide. Next. So we focus on ongoing didactics and mentorship that's easily accessible from anywhere. Next. So we take providers from going through the case and literature, through interpreting images, understanding common pitfalls, troubleshooting, and finally the clinical integration. How do I take this knowledge and make the best clinical decision based on the literature? The platform contains modules on all of the core Pocus scans in an easy to follow format. We've also included content here for musculoskeletal ultrasound and office-based procedures that would be more common in family medicine. We also have pediatric lectures, dermatology lectures, so we wanted to expand the breadth of Pocus education. Lectures are also followed by summaries and brief quizzes to test knowledge. And we tried to design lectures to be as fun and engaging as possible so that the core concepts stick. We wanted them to be brief and small tidbits so that knowledge can be retained. And we all know as providers, everyone's very, very busy. We don't have a lot of time to spend hours and hours listening to lecture after lecture. And so the lectures are broken up into smaller, shorter segments. Next. Beyond the core content and modules, we begin addressing the needs of residency programs as well, helping them establish their own Pocus training, ongoing mentorship and faculty in reviewing scans. And it's been really interesting doing mentorship sessions remotely. I thought it was going to be much more challenging with Pocus being such a hands-on skill. How do you teach a hands-on skill when you're not in the same room as a learner? And through teleguidance and online teaching, I find that as a teacher, having to guide a learner by watching the learner move their hand, manipulate the probe, and watching what they see on the screen, having to guide a learner that way in order to obtain the best quality image, it's challenging, but it also forces the learner to arrive at their scans themselves. And so ultimately, I think it's much more empowering, and it's been a really great experience thus far. Next. We're excited to say that since 2018, we've built a global community of nearly 1,000 learners, experts, and continue to grow by addressing the barriers to Pocus education and adoption. Next. Despite never getting to meet my grandfather, next, he left behind a legacy and an enduring reminder that access to healthcare is not a given, that it has to be fought for and not to be taken for granted. Thank you.
Thank you so much, Mina. That was truly fantastic. You had mentioned to me you were going to start with a case, your own case to hook us, and I had no idea it was your grandfather. That was fantastic. So now I'm going to pull up. Normally I cut us off at everybody was so great. So we're going to keep rocking as long as you all can stay here for Q&A from our audience members. So I'm pulling over Grace and Sally. Thank you so much all for your really fantastic, just sharing all of your fantastic experiences and cases and educational experiences with us. So I'm going to come to the chat here. I think we should maybe have some questions. I forgot to tell you all in the beginning to please submit questions via whatever platform you are sharing from. Oh, okay. Well, so far, no questions, but I know that at least 82 people signed up for this. So you should tweet right now. Our good friend Shantanu here is like stalking online. So if you have questions, you can tweet them. I think Facebook failed, YouTube them, LinkedIn them. But I think one thing I would love to pose for each of you, while we're waiting to see if there's any audience questions, is what would you say is your single biggest takeaway point? Like, what's one thing, look back at 5 year ago self, what's one thing that you really wish you would have known? And just looking at the screen here, Mina is to my left. So I'm going to start with you, Mina, and then we'll go Grace and Sally.
Well, I think in the last 5 years, and I talked about this during my talk, I would have spent less time just teaching introductory Pocus courses and instead developing longitudinal training systems, because I feel like there was a lot of energy and time spent on just introducing the concept in places that may not have had or the infrastructure, the what to do after the course is done plan had not been established or laid out or really thought through. And I think what I've learned is that ongoing longitudinal training is absolutely necessary beyond an introductory 2-day course in order to develop the confidence that's needed for learners to actually get the probe in their hands and scan, because that's really where the continuous learning happens. And there'll always be scans that you don't know how to interpret, or a scan that's difficult a view that's difficult to get, that needs to be troubleshooted. But if you don't have the confidence to pick up the probe to begin with, then that learning will never happen. So I think that was my big takeaway from the last 5 years in Pocus education.
Fantastic. Thank you. Agreed. How about, I said, Grace, you were next.
So what I wish I'd known, although I don't know if it's really possible to know this going into it, but when you're looking into introducing Pocus in different contexts, I mean, we talk about doing needs assessments and doing things that are context specific, but there are things that you just kind of have to be open for and that I didn't consider. I mean, one of the things that and I'm sure we're going to talk about it in terms of a barrier, was that being in Kenya, I was in a country so I'm an emergency physician in a country that did not recognize emergency medicine. When I started working, I didn't know what emergency medicine was. And so when you go and start teaching, people want to know emergency medicine, what is that? And then, point of care ultrasound, what does that mean? And how do you get certified for it? In my country, you really have to demonstrate, the kind of certification that you have for people to really accept and embrace the training. So first of all, an emergency physician, so I have to explain that. And then having to explain that, point of care ultrasound is part of my core competency. It's something that I'm expected to know. So, just by having done the emergency medicine residency training, which they call a master's, by having done my master's, I'm already qualified in point of care ultrasound because it's required. So being able to communicate that, and also like Mina was saying, I started off the same way, just doing short courses, 2-day courses, this and that. But then with time, you start to realize that you have to create a system and infrastructure. And that's when things like, in my country, we are contending with figuring out what the certification is going to be, because we have to have a body that is recognized, because they say that, what's to prevent people from just going and getting a 2-day course and then, you go open your small little radiology office and start charging patients for it. Yeah. And so being certified and, the medical council being able to say that, hey, this is legitimate. These are aspects of creating a system and a training program that is sustainable that, didn't occur to me at the beginning. I was just excited to the care ultrasound. I didn't anticipate some of these barriers. So.
It is so fun and exciting. It's hard to know those things. And how about you, Sally? And then we have a couple other ones I'll kick back.
In an effort not to repeat the wonderful points made by Mena and Grace, I think maybe one thing worth recalling is you really have to master the basics before you, as either an educator or as a clinician in an environment that is distinct from the traditional environment that you're used to practicing in before you go into that environment with your Pocus skills. So again, I think the points made were exceptional, and hopefully I would have thought of one of those on my own if I had gone first or second. But I just want to say it's a humbling reminder to remember that we're always building our own capacity so that we can improve the capacity of others in a capacity building role as an educator. And so really making sure that we are solid on our own basics, that when we're in an environment where Pocus is maybe the only imaging modality available, we feel comfortable extending the foundation that we already have and maybe doing applications that we wouldn't normally do as a part of what we were trained to do in our previous clinical environments.
Absolutely. So this kind of dovetails off of that, and anyone can call dibs on this one. But there's questions about, what are the biggest obstacles to get your closest colleagues to even take a look at Pocus? Fear, radiology, costs, et cetera, was, kind of some of the things that they had put in there. So just curious. I think fear is a big one for IM, FM, more traditional.
I can talk about, particularly teaching at Kenyatta National Hospital. This is a national and a regional referral hospitals. And so this is a hospital with a large tradition of teaching medicine, internal medicine, surgery, radiology. They are all very established, departments. And so, coming in and introducing something like this, which is, cross-cutting, it's emergency medicine, it's radiology, it's, trauma, so it includes, surgery. There was, sometimes you get a little bit of pushback, like, what exactly are you trying to do? Are you replacing the skills of the radiologist? Are you not going to need a radiologist anymore? And one of the videos I was trying to play that didn't come across very well, when we were rotating in the ICU at KNH, one of the doctors was trying to explain the kind of things you can do at the bedside, and someone asked, so are we trying to replace radiologists? And so it's making the case that, the questions we're asking are different than what the radiologist would be looking for. We're looking at for a yes and no answer, and that, the answers that we get help us to do more targeted imaging requests, to X-ray, CT, MRI. And so radiologists will never not need them,
Yeah, for sure.
So I think that's a big fear. That's a big pushback. Like, what are you doing? Are you trying to replace an entire, specialty in medicine?
And I love that you said that, Sally, at the beginning, when you got to your question mark cases, this goes against everything I teach my learners, focus, binary, yes, no. Mina, from family medicine docs, what have you found to be kind of the biggest obstacle in your, not at Contra Costa, because you're, totally rocking it there, but national family medicine docs?
Absolutely. So I think it's important to distinguish between family medicine doctors who are out in practice, have been out of residency for several years, and family medicine doctors in training and residency. I think it's much easier to get Pocus adopted in a Pocus training program adopted in a residency, because it's still, doctors are still in training. They're supposed to be learning new things. That's what residency is for. But beyond that, within the last few years, the American Academy of Family Physicians has come out with a statement and recommended curriculum guidelines for point of care ultrasound. So family medicine is several decades behind emergency medicine in this respect. You can't finish an emergency medicine residency today without obtaining core Pocus skills. And I think in family medicine, this is also going to happen, and in other specialties as well. I think it's just a natural progression. Even in medical schools, there are more and more medical schools that have Pocus programs. So you have medical students who are going to become residents who are like, hey, I know how to do, I'm familiar with these ultrasound skills. I want to learn this. I'm in residency, which then kind of forces, it's a one-way moving train, forcing faculty at residency programs to get on board. And I think, one of the most difficult pieces to overcome for an individual provider, especially out of residency, is as doctors, we spend so much time in medical school and residency acquiring all this new knowledge and all these new skills. And then we finish and we go out into the world and we practice medicine, and we have our way of doing what we do based on what we've learned in our journey and what our patients have taught us. And so it's extremely difficult, a heavy lift to then acquire a new skill such as point of care ultrasound, especially if you're even just the hand and eye coordination of it's almost a different part of the brain having to form new neuron connections. But I think one of the ways to overcome that fear is actually showing someone a point of care ultrasound, doing it on yourself or a colleague, and showing them, hey, you can do this. This is it's very, very doable, and getting someone excited, igniting that passion to take the time to learn it.
Renee, can I add?
Please do. I was on mute because the Airbnb I'm at, the garbage man is here. So Sally, please. And then again, everybody, like, pop off whenever you have to. Your time is so valuable. I'll keep going with a couple other questions, but to our speakers, thank you. You can hop off when needed.
I will try not to repeat the exceptional and very well stated points already made in response to this question. I think a few things. Number one, I agree with Mena. I think this is a one-way train. It is inevitable. It is only a matter of time, and you'll have early adopters and you'll have late adopters. And it is inevitable that Pocus is going to be incorporated as an extension of the physical exam. Second, I think one hurdle is actually conceptual. A lot of us are educators and we are surrounded by educators, and many people have a fear that Pocus is going to separate or create distance between the patient and the provider. And I think that as soon as people experience Pocus and they're using Pocus on their own patients, they discover that it actually breaks down the barriers between patient and provider. And it actually makes patients feel more heard and more seen, and they feel like they're spending more time with a physician. So sometimes I think it's conceptually, it's that heavy lift. It's helping people see and experience that actually Pocus connects us way closer to our patients than it could possibly separate us. And I think that's an important thing for people as they develop curriculum and incorporate Pocus.
110%. Having spent the first 2 weeks of 2021 on the hospital wards, people love it. There was one question. Has anyone seen, so Journal of American College of Radiology published a piece. Preprint came out in September. It came out in January in print, where they're like, oh, there should be 4 types of Pocus depending on what you do and what you look at. I saw an editorial or maybe a tweetorial response to it saying, like, don't tell me my business, but like the Pocus is more than that. I will say I love Dr. Bruce Kimura has a piece called Contextual Ultrasound, which is like, are you in the ER and you're doing a kind of like a not comprehensive, but you're limited ultrasound study where you are recording and documenting and doing a certain protocol, versus I'm on the wards and I'm like, yes, no beelines, move along. So there's contextual. Did anybody see that JACR piece? If not, to Dr. Max, sorry, but search for it on Twitter. Anyone see that one? No, I think I got some shaking heads there. Thank you, Anna McDonald. A question from someone else. I love it when we get questions. It's so exciting. I've been working with Pocus in Malawi for 5 years and run into the challenge of procuring ultrasound machines that can be left behind for those who've been trained to use in their daily practice. Any advice? Thinking about how to build equity and sustainability into these very beneficial training programs. I'm going to take that one first, and then we can kick it to those of you who've been in Malawi. But so this is supposed to be it's called an EduCast. It's not called like a sales cast. The entire thing is not to be about like, oh, look at what Vave does. I'm doing it, and we picked this because global health is a true passion of the company and of the founder. And so that is somewhere that we would love, a space we would love to be in and actually create longitudinal relationships with organizations and be able to train up and leave them with their own devices, they're like nice little ones that they can Vavecast, et cetera. And so again, this is not a sales cast, but I will now say that it's totally on our radar as a company. And now I'll let, I think, Mina, you're the one that has been in Malawi the most. Kind of, do you have any advice about that over there?
Absolutely. Well, I will say that we are lucky to be in a time where ultrasound has developed to be much more affordable and smaller and portable and durable than it has ever been. At Gussie, we're company agnostic, so I won't say you must get this type of ultrasound for all of your learners. I really do think that any ultrasound that you have that's available is going to be useful. Sure, image quality will vary, but I think that's part of mastery in learning ultrasound is knowing what your limitations are, knowing what questions you're actually able to confidently answer based on the machine that you have and the image quality that you have. But I will say that it's a great question. I think there's a lot of opportunity for partnership in Pocus education, and that has to inevitably include access to machines.
Agreed.
Anything else? The other thing I can add is that, definitely, cost is a huge consideration working in New York, Kenya, for sure. And so, I agree, and I really appreciate the moment that we're in, that, the machines are getting cheaper and more affordable for our facilities. The program that I started working with, we were lucky to have some grant funding to support that. But thinking about sustainability in the future, the cheaper the machines get, the further we're going to be able to go. But then I also found in some of the hospitals in Kenya, there are, governmental programs that kind of come and go that sometimes include equipment donations. And, those ultrasounds, they go and sit in a corner somewhere. Like one of my colleagues was saying, if it goes and sits in a corner somewhere, people don't know how to use it, or they really only use it when a pregnant patient comes in. And so being able to, figure out if there's something there that they already have and that they can, kind of use and repurpose and bring it more to the front line also helps whenever it's available.
The only other thing that I can think to add, in an effort to be company agnostic, obviously the handheld probes have their benefits. I would encourage those of you seeking to get machines and secure machines for certain environments to reach out to companies and see what their support for the global health environment is, because some companies certainly do have discounted rates for both machines and probes, and also have some sort of a comprehensive support program to prevent exactly what Grace was just describing, where machines are sitting unutilized after there's some sort of malfunction and someone says, oh, we don't know how to fix it. And so it becomes a very expensive, overqualified paperweight. So I would encourage you to reach out to various companies and inquire what their potential support is of programs from a low resource setting.
Awesome. Well, this has officially gone like 30 minutes longer than my longest EduCast, or at least 15, because you all were so fantastic and the questions kept coming. So 2 different people put in comments saying to our speakers, thank you very much for sharing your knowledge and expertise. They very good presentation. So it was fantastic to have you all, and thank you again. Our next one is going to be February. Let me actually make this big. Our next EduCast is going to be, oh wait, if I do that, you won't hear me, I don't think. Anywho, you can see it down here in the corner anyway. Our next EduCast is going to be Thursday, February 25th. Yes, please run, Sally. I've taken way too much of your time. Thank you all so much. So I am going to tease you all and just tell you it's going to be fantastic speakers, super interesting, talking about passion projects. And we'll release more info as soon as we have it. So have a great afternoon, everyone. And thanks for tolerating my tech gaps from a single laptop. It was rough. Bye.
Bye. Thank you so much.